Welcome, everyone, to the All Out Coach podcast. This is the first live broadcast of the year. My name is Tim Mikhelishvili. I'm your host, also CEO and co-founder of Amadev Pharma. We have a deep metrics proprietary platform that helps medical organizations scale their patient outcomes faster. Today, I'm joined by a cardiac heart transplant surgeon, an expert in machine learning, informatics, health economics, and population medicine. He's also been recognized as the health hero by the city of Boston. He's a returning guest. His name is Dr. Pierantonio Russo, currently Corporate Chief Medical Officer at EVERSANA. And he will share with us some highlights from a recent state-of-the-art masterclass presentation that he delivered in Rome on the healthcare innovations of the hospital of the future, and also tell us about the reality of designing that healthcare system that we all dream about today. Welcome back, Dr. Russo. Pierantonio, nice to have you. Thank you. Let's begin by talking about your journey. Would you please introduce yourself again to our audience? And I want to remind, by the way, those who are tuning in now that we're live on LinkedIn, Facebook, and YouTube. So you're welcome to ask your questions, send your comments. It's a very unique opportunity. So please take it away, Pierantonio.
Thank you, Tim. Good morning, everyone. Again, I'm Pierantonio Russo. I am the Chief Medical Officer at EVERSANA. I started as a cardiac surgeon, heart transplant surgeon. My first job in this country was at the Mayo Clinic, and then I continued in Philadelphia and at the University of Missouri as a director of cardiac surgery, heart transplantation, and pediatric cardiac surgery. So I practiced cardiac surgery for more than 20 years. And then towards the 2007, 2008, I reduced my practice and started an executive career, first as medical director of the Independence Blue Cross, and then as vice president for medical clinical affairs in Boston with the Harvard system on the insurance side. In Boston, I was also lecturer in population health at the Harvard Medical School. However, between 2007 and 2015, I still provided care, charity care, surgery in developing countries on behalf of Gift for Life International. During my executive career at Independence Blue Cross and at Harvard Pilgrim, I had the good fortune to work with fantastic data scientists with whom I collaborated on starting to use predictive analytics, machine learning data, and social determinant of health data in order to inform the predictive analytics needed to support value-based contract, value-based care, and of course the case management and population medicine. Before joining EVERSANA in my current role, I also had the opportunity and privilege to be Chief Medical Officer for two health service organizations, one co-founded by the Blue Cross Blue Shield Association that offer an integrated approach to internal medicine and family medicine and psychiatric care, behavioral health care. And the other one is a population service organization in which I was Chief Medical Officer in Jersey. As a Chief Medical Officer at EVERSANA, among the usual function of the Chief Medical Officer, I also manage the relationship with the NIH on the study of rare diseases. I have a certificate in health management and also in digital medicine.
Thank you. What's interesting and unique about your experience, I think, Pierantonio, is that you have a very well-rounded and comprehensive view of the healthcare delivery system based on the roles and the experiences that you've had. So I know that the title of your presentation in Rome was Hospital of the Future. And, currently, because of the advances that we have in technology, I think that the future is something that we are building now ourselves. And that's why, we called this discussion and the title of this podcast today, designing the delivery of our dreams. And I thought, I wanted to share with you what I think, how I define that healthcare system of our dreams. And I think that's one in which the patient can access any treatment, regardless of the city or town they live in. That they can have continuity of care as they move through the system, whether or not they lose their job, they change jobs, they retire, they change physicians or hospitals, and that because of the advances in medicine, they can expect to receive the highest quality of care. So that's how I define, the dream of the the healthcare delivery system. As you know, that was our theme last year at the Medical Affairs Innovation Olympics, where you spoke as well. But I want to ask you about, those kinds of innovations that are already underway, which you've highlighted in that state-of-the-art presentation. What are some of those specific innovations that you're excited about, and which ones do you think are going to have the strongest impact?
Well, indeed, Peter Drucker famously said that in order to predict the future, you really need to build it. The best way to predict the future is to build it. And I was blessed, as you just said, that I had the opportunity to leave the academic and clinical practice in some of the best organizations in this country. And then see the payer side and the population health side, and now, of course, the data and analytic, working with fantastic data scientists at my organization. So with that point of view, with that vantage point, I can say that already we have a number of groundbreaking innovation that have been changing the landscape of healthcare in this country and even elsewhere and even abroad. And most importantly, we have the opportunity to see the results of some of this new groundbreaking innovation, learn from those lessons, and start to build future solutions. I would say that the past, of course, represented here by the first hospitals in this country, which is the Pennsylvania Hospital in Philadelphia, and the future are so different in that the past really was based on, and is still somewhat today, based on hospital confinement. The patient is confined in the building, and all the recording is on paper, and the patient did not participate in his or her care, did not have access to his or her records. Today, we have the opportunity to provide care anywhere. So we can provide care in a physical building, but also in the home, in post-acute care, ambulatory care. And the major advantage of the digital solutions that we have today is that all these care systems, virtual and physical, can be connected with one digital platform. So the doctor who is taking care of you in the hospital now can have access to your post-acute care data, or may be able to follow with your doctor, with your personal physicians, your evolution of following the discharge from the hospital with remote patient monitoring, right? And you can have access through various portals to your own records. And of course, we have a number of immediate solutions in some of the hospitals that have improved care dramatically, like, for example, like you are showing here, secure customized patients portal, where the patient can have access not only to his or her records, but also book appointments, book post-acute care appointment, to talk to his own or her own doctor from the hospital bed, may have actually access even to bills and copays, and other health service organizations tools that may be helpful for education and for continuous engagement with the healthcare system. I think one of the most promising innovation that we have seen already being very successful in several hospitals in this country, for example, Johns Hopkins in Maryland, in Toronto, and even in England, is the Bradford Infirmary in England, is the command center. Think of the NASA command center, where essentially a bunch of physicians, clinicians, and technicians and AI experts coordinate your care wherever you are in that system. So the command center can have access to the data in the emergency room, in the operating room, on the floor. They may be able to identify, because they have also access to vital signs. They may understand that now there is an emergency, I need to send resources in that particular area. They may improve flow by accelerating discharge so that the emergency room visit time is reduced significantly. So the command center, again, like the NASA command center, has been extremely successful in streamlining the care, the efficiency of the operations in the hospital, but also making it safer and connecting not only the hospital data, but also all the clinics associated with that health system, so that one can decide where is the next discharge should occur.
Yeah. You mentioned NASA, and those images do remind me of NASA, center. So are you telling me that some of that is already taking place in some of those hospitals? So it sounds like you're nodding your head. So that's already underway.
For example, Johns Hopkins has published their results. There are other hospitals in Toronto. Humber Hospital in Toronto. There is another one in England, Bradford Infirmary, that have published their results. And essentially what they've shown is that there is improved patient satisfaction, there is improved physicians and clinicians and nurses satisfaction, because there is a more coordinated care, which is somehow guided through data that is collected at each point of care. Right, and at the same time, that data is analyzed, alerts are sent at the appropriate point where an intervention is needed. Right, and so the emergency room visits time is reduced because you are accelerating discharge, and so the patient now has a room. Same situation, the operating room post-acute care, post-surgical care unit may be efficiency may be improved because now there are more beds available on the floor, and so on. And again, dispatch of resources where they are needed is all guided by a control center that collects all this data and analyzes all this data.
Yeah. So the reason I asked that is because I wanted to, follow up why you think that certain hospitals, certain institutions are achieving those outcomes and are more successful in implementing digital medicine. Johns Hopkins, you mentioned Bradford, right?
Well, I mean, as always, the centers of excellence like Johns Hopkins, Mayo Clinic, Cleveland Clinic, University of Pennsylvania, you always have pioneers, right, in health systems and in healthcare. And the organizations that are willing to embrace innovation not only learn from the lessons, but then they teach those lessons to the rest of the healthcare system. The bottom line is that I strongly believe that what has been heard over and over, that the AI will not, artificial intelligence and digital will not replace human, but definitely human who will not use artificial intelligence and machine learning and digital will be replaced themselves. So, so I think it is extremely important to understand that, of course, we have work to do to implement this innovation, as always, in an ethical way, in an equitable way, in a responsible way, but we cannot ignore innovation. We need to embrace innovation and improve based on lessons of the first pioneers, like we have done always in cardiac surgery, we have done it in oncology, we have done it in every part, in every sector of medicine.
So here is another speculative question, I guess, and I just want to ask for your opinion. When you think some of these innovations will actually touch other community systems at scale? When will they go mainstream, do you think?
Healthcare is slow to change for obvious reasons. There are safety issues. There is protection of patient data. There is obviously caution that because we don't want to do harm. The first lesson, the first goal in medicine is in healthcare is not do not do harm. But because of that, is going to take, and then of course there are also capital investment that are needed. So it may take at least a decade to have scale. However, all I can say is that there is significant innovation going on in this country. Think of the hospital at home. So there are several institutions, several hospitals that have connected with the community and with care coordination companies to provide care at acute level in the home. So there are 10 to 15 conditions now that have been proven to be been validated with experience since 2017 that can be, again, treated in the home exactly like you would receive that care in the hospital. So right. You have a nurse, you have telemedicine, you have all your tests, your imaging done in the home, you have your infusions. And so, and of course, again, as I mentioned before, that is possible because of remote patient monitoring, because of predictive analytics, who is going to be the patients more suitable, and continuous connection with digital, with your healthcare system and with your physicians.
Yes. Pierantonio, you touched on some of the patient outcomes. Can we dig a little bit deeper and talk about some of the specific benefits to patients and the patient experience of predictive medicine, of machine learning?
Well, let me start by remind you, for example, that continuous glucose monitor now has been improving the care of patients with diabetes 1, but also complex diabetes 2, type 2. And why? Because we used to treat patients with diabetes only based on one snapshot of the A1 of the glucose within A1C, right? Now we know what happens to that patient over 24 hours, for example, right? We know what happens to that patient during the day and night, and that information is all available to the patient, but also available to the physician. So not only there is a continuous connection between the patient and physician, but also there is a self-care component that starts with understanding what happens to your glucose level. Remote patient monitoring for patients with heart failure has changed the way patients understand their physiology, right? They see when the weight is up because they perhaps ate too much salt or drank too much Coke or soda and so on, right? And so that remote patient monitoring has allowed patients to with hypertension or with remote or with heart failure to continuously monitored, and then an intervention can be devised appropriately before the patient is so sick that needs to be sent to the hospital. These are concrete improvements that we have been able to identify through digital technology and implement through digital technology and through continuous connection between the patient and the physician. Then, of course, you are showing here an experimental robot, still experimental, but the initial data has shown that a robot that draws blood gets it right 83% of the time. Why? Because they are using a ultrasound which is connected to the machine. So so instead of doing a blind injection in blind search of your veins, the robot is actually guided by imaging. We shouldn't forget the utilization of robot in hospitals. There are hospitals actually. Well, this is what you are showing here is the software that helps with the real-time colonoscopy in helping the physician to identify a certain adenoma during colonoscopy that perhaps the physician has not been considering being malignant, but based on machine learning, predictive analytics, the training of that software with thousands and thousands of similar patients guide the doctor to actually take in consideration those adenoma. But I was referring previously to robots that actually help with all sorts of tasks in the hospital. Robots that actually can ride the elevator and transport linen, transport drugs, transport trash, right? And exactly right. And there are several hospitals that have implemented already this robot. And what has been shown that there is a tremendous increase in nursing efficiency and reduction of errors. There is a study from Harvard that has shown that every 37 minutes a nurse in our hospitals encounter a problem, most of the time due to logistics, and try to solve that problem. But the logistic problems may actually take away 12% of their time that otherwise should be dedicated to patient care. The implementation of this robotic technology actually has shown clearly improvement in those logistics error, and therefore more time for the nurses to dedicate to patient care.
So it sounds like I had forgotten to mention one other important factor in defining this delivery of healthcare of our dreams, which is convenience as well and workflow. Right? It's not just about access, continuity, and quality, but also convenience, which you reminded me when you and I have spoken.
Yeah. So I mean, we need to go back to the early 2000s when the Institute of Medicine started to talk about the quadruple aim. Right? The quadruple aim is refers to the optimal quality care, a reduced cost, so more cost efficiency, and improved patient, but also physician's experience. Right? People have been learning about physician burnout. Physicians are spending an enormous amount of time for recording for administrative tasks. Well, there are solutions now already available in many hospitals where the dictation of the documentation of the chart can be supported by recording the conversation between the patient and the doctor, and that recorded conversation is transferred into a clinical notes that is first evaluated by the physician. Is this corrected by the physicians? Additional information is inserted in that note from the electronic medical record automatically, and then once the physicians the accuracy of that note, the note is transformed in a format that is suitable for clinical documentation. So just that improves the physician's experience, but also provide more accuracy in recording, and so improve quality. And in terms of patients' experience, I would say that the ability to use telemedicine, the ability to use the televideo, reaching your doctor anytime either your doctor or someone else, but qualified. It is extremely important because during the pandemic, we would not have been able to provide care without television, right? So, and telehealth. The what we call digital front doors, ways that, essentially think of an app, right, that you can download on your computer, on your iPhone, on tablet, that gives you all sorts of information about your condition, and that gives you tips on how to manage your day, tips on how to manage your mood, right? Connecting your findings and your current state to the doctor. You're picking up your clinical and physiological data. You can do an EKG, right, with two fingers applied to a solution that wirelessly is connecting with your phone, and therefore then can be sent back to your physician. So all of this is convenience and continuous engagement and improved quality of care.
Sure. Thank you. I wanted to make sure to show this image as well in terms of the convenience, the documentation, which you already discussed as well.
And again, this is only possible because of the large language model and AI that can essentially transform one way of communication, which is oral communication, verbal communication, into text, right?
Yep. Pierantonio, we would be probably remiss if we don't talk about some of the challenges and skeptics that still remain. I know your enthusiasm and my enthusiasm, of course, when it's used in the right way. Many people say that some of these technological innovations, machine learning, can maybe compromise that art of medicine. What is the impact and what is the challenge of this innovation and decision-making from your perspective?
Well, first of all, I completely support the concept of art of medicine, because we know that whatever we learn from a randomized, double-blind, prospective clinical trial is extremely important as a first step to understand the effectiveness of a new therapy. But when applied to clinical practice, the situation is completely different. The findings may be completely different. Or somewhat different, because there are so many other factors that may impair the applicability of what we learned from the clinical trial, right? And so this is why we do a lot of work on real world evidence. So, okay, this is the results from a clinical trial under experimental condition. This is actually the real-world evidence that we can collect from real-world data, from real-world patients, from real-world physicians who not always have the expertise as the physicians who ran the clinical trial. So there is always an art of medicine. And the other component of the art of medicine, of course, is to treat the patients as a whole and to make sure that the emotions and the behavioral health and the spiritual need of the patient are taken into consideration.
Okay.
But I would say that today, the convergence of large number of data, diverse data, clinical and social, right, and environmental, together with mathematical algorithms and the power of computers, allow us to digest all this data very quickly and analyze this data and come up with trends and patterns that then can be translated into a predictive analytic based model. And those predictive analytics allow you to identify the predictors of outcomes. And so I would say that the art of medicine actually could be improved dramatically by applying this responsibly and ethically, this new method of understanding the real world evidence.
What are some of those real world benefits of, from a financial perspective, to our healthcare system, which the costs of which are just increasing every year? Right now it's 1/5 of our GDP in the United States, which is twice as much in the rest of the world. So what are some of those examples and scenarios that you have witnessed yourself or you envision from?
The large payer organizations have been starting using predictive analytics, data science, even social determinants of health in the predictive analytics back in 2012, 2013. Here in those organizations, really, I learned how to apply this concept working with my colleagues in data science. And I would say that this large number of data digested through mathematical algorithms, adding, and I'm very bullish about using the social determinant of health, because it is a reality that the outcomes, clinical outcomes, depend on the way you interact with the healthcare system within your ecosystem.
Absolutely.
Right?
Absolutely.
And so definitely have supported the implementation of value-based care. We have much more data now that tell us and insight from the analysis of that data, what is low value care, so care that add very little to the outcome of the patient, and appropriate care, that it is the right care to the right patient offered by the right physician, right, in the right location. And so we do a lot of work even at EVERSANA on predictive analytics that support precision medicine. That means, again, what is the right drug or the right treatment for the appropriate group of patients, and what are the appropriate settings.
Sure.
And I think that the payers have been actually very good at least certain payers, at implementing this approach to support value-based care, to support value-based contract, and case management and disease management.
So ML can be used to take the insights on social determinants of health as well and improve personalization of care, correct?
I believe that any protocol and any machine learning predictive model can only be valid if we introduce the social determinant of health, the ethnicity, the diversity of data, because otherwise they only apply to the population that has been where the algorithm has been trained on, right? Yep. So again, given the computer power and large data available, the responsible approach to these predictive models is to include as much as possible of the data from ethnicity, from income, and of course other aspects of the social determinant of health.
And I think that large employer groups and organizations, they invest a lot into the healthcare of thousands of their employees, and I think all of this technology can only improve the cost, reduction of costs, and just personal delivering the right care to the right patient at the right time, like you mentioned. So
yeah, absolutely.
Yeah.
I mean,
would you like to add anything?
No, just one thought, that until a few years ago, we had only statistics to come up with the digesting the data. Today, we and statistics require essentially starting with an hypothesis. Instead, machine learning allows you to start with the concept of I don't know what I don't know, and I want to discover things that I don't know. And this is possible only because of the convergence of large number of data, diversity of the data, and most importantly, computer power that can analyze that data.
It seems like that quote that physicians will not be replaced by robots, but physicians will be replaced by those physicians who know how to work and manage with technology and robots, if you will.
Correct.
I think that applies, I think, very well. It can improve your intuition and the art of medicine when you have more data in your hands.
Physicians and also institutions, right? Building offices, because right now the artificial intelligence tools have been able to streamline back office procedures as well as efficiency of building management. So not only safer, more efficient, and less costly.
Okay. Yeah. So there's clearly a lot of data points that Dr. Pierantonio Russo has available that you can inquire. You can please contact him at EVERSANA. I want to ask you one final question. Take a couple of minutes to share your final message, Pierantonio, with any critical steps that our audience listening should take in educating themselves when they consider what technology, what AI model to consider for their care as patients or providers.
Right. So, I mean, to my colleagues, I would say start to educate yourself, if you are not familiar already, with the applications of the digital medicine as well as predictive analytics that can support the heuristic approach to the care of your patients and establishing protocols. There are various sources, some of which are now even for education, even provided by some of the large medical schools and advanced medical schools. To the patient, I would say don't fall for the hype, of course. Always discuss with your physician whether or not a certain tool that has been offered to you is FDA grade, for example, has been validated scientifically, and that is proven to indeed change the way you connect with the healthcare system, as well as improve outcomes, clinical outcomes. With respect to the progress that must be made in order to slowly scale machine learning, AI, and generative AI, right? We need to think of the number one, how to build a strong data infrastructure. We need to collect data, and we need to obviously keep that data safe. The patient privacy must be protected, and therefore cybersecurity needs to come at the same time as the infrastructure that is built for the data architecture. Digital solutions are already available. As I said, many of them have been validated and extremely helpful to connect patients and physicians and to educate the patient and include the patient in his or her own care. And finally, I would say that if I had to advise CEOs of hospitals that are not yet on this journey, start again with cybersecurity, data infrastructure, and most importantly, start with improve your efficiency through some of the AI solution already available for back office to support the physician recording and documentation, and to improve the connection of the patient with their records and their physician.
Thank you, Pierantonio, very much. I hope that those of you who listened will connect, ask questions. I can tell you from personal experience and just knowing you for quite a few years now, that you have some amazing, unprecedented case studies and examples in which technology has transformed care. And so if you want to listen to this conversation, make sure to subscribe to the All Out Coach podcast. Visit our website at amadevpharma.com to stay in tune. I'm welcoming you to come back anytime you like to share more and educate us, Pierantonio.
It was a pleasure. It was a pleasure. Thank you so much.
Thank you.